Hello and welcome to Radcliffe Cardiology's live webinar in association with Medtronic. I am Professor Wolfram Doehner from the Charité Medical University in Berlin, and I'll be moderating this webinar today. It's a pleasure to have two well-known experts on stroke in cardiology with us today, and I'm pleased to introduce Professor Georgios Tsivgoulis, who is a professor of the neurology at the University in Athens in Greece, and Professor Robert Hatala, head of cardiology and angiology from the National Cardiovascular Institute and the Slovak Medical University in Bratislava, Slovakia. They will present and discuss today the link between atrial fibrillation and stroke, the importance of personalized treatment, and how prolonged cardiac monitoring improves outcome in patients with cryptogenic stroke. This is an interactive session, and I encourage you to ask the panel questions using the text box on your screen during the course of the webinar. Our panel will aim to answer as many questions as possible at the end of each of the presentations. You also have the opportunity to participate in our live opinion polls, so please feel free to join in. If you wish to participate in these polls and you are watching this in full screen, you will need to return to a smaller view to see the voting options that are available. So to start the webinar and to gain an understanding of you, our audience, we have a short poll question available now on your screen. In what percentage of your patients with cryptogenic stroke do you currently use an implantable cardiac monitor? Is it option A, lower than 10%, B, 10 to 25%, C, 25 to 40%, or D, even above 40%? And while we are waiting for our audience to come back with some answers from their own situation, of course, I would like to know from you how you do this in your institute. Robert.
Well, first of all, we are a department of cardiology, so we are working only with patients who are referred to us for this particular purpose. But I'm afraid that overall in my country, the percentage of using implantable loop recorder in post-stroke patients is relatively very low. So I would vote for the first option. Is for sure less than 10%. However, we have started some initiatives together with our colleagues, neurologists, to improve this.
Okay, thank you. Georgios.
Our center in Athens is a comprehensive tertiary care stroke center that a lot of patients with cryptogenic stroke are referred for further diagnostic approach. So we're implanting approximately 15 to 25% of the cryptogenic stroke population.
Okay, thank you. Now let's have a look at the results. I can't see them right now. It's 54% for option A, so below 10% of. It's 18% still for option B, 10 to 25%. 27% voted for option C. And none for the last option, which would be above 40%. Are these results somehow expected for you?
Well, yes, I must say I have expected this. First of all, it's the problem of dissemination of knowledge about new technologies which allow for better ECG monitoring and for better detection of atrial fibrillation. And then we should also mention there are some economic issues with using of these devices.
Yeah, I also expected these results because a lot of colleagues prefer to perform repeat 24-hour ECG recordings that I don't find very effective in terms of detecting paroxysmal atrial fibrillation, and this may also result in lower compliance of patients with implantable cardiac monitoring because they're tired of all this diagnostic testing.
Absolutely, which we will also hear more about in your presentation later on. Okay, great. Now I'm going to hand over to our first presenter, Dr. Hatala, who will discuss the link between atrial fibrillation and cryptogenic stroke. Robert, please.
Thank you. Good evening, ladies and gentlemen from London. First of all, I would like to express my gratitude for inviting me to this interesting event on, I believe, a very exciting topic. My task here during the following minutes is to share with you some facts and thoughts about the link between atrial fibrillation and cryptogenic stroke. Now, we know very well from clinical experience, especially in the last years, that the post-stroke management becomes more and more challenging interdisciplinary issue. About 15 to 40% of all ischemic strokes have no identifiable etiology, and they are defined as cryptogenic stroke. We know that the key aim of post-stroke management in all stroke is the prevention of recurrence by eliminating or at least minimizing all risk factors for stroke. And we know very well also that atrial fibrillation is the single most powerful predictor of stroke. The risk of stroke in patients with atrial fibrillation is increased by a factor of 5. The risk of stroke is independent, at least with the current accepted state of knowledge, is independent of atrial fibrillation type. That means paroxysmal, persistent and permanent all have their stroke risks. Strokes in atrial fibrillations are usually cardioembolic, and we know that they have a high mortality rate approaching almost 50% for the first year. There is a very high recurrence rate, but importantly, about 1/3 of ischemic strokes or transitory ischemic attacks are of undetermined cause, and these are called cryptogenic. Now, the latest ESC guidelines we have available recommend in patients with strokes screening for atrial fibrillation by short-term electrocardiographic recording followed by continuous ECG monitoring for at least 72 hours. So, and this is a class 1 recommendation, so a very strong recommendations. We have also another recommendation in stroke patients, and this is that additional ECG monitoring by long-term non-invasive ECG monitors or implanted loop recorders should be considered to document silent atrial fibrillation. And this is a class 2A indication. So we have quite a strong background to implement these strategies into clinical practice. But what we see in real life is a different scenario. These data are from Canada, from Ontario Registry of Strokes, with more than 17,000 consecutive ischemic stroke patients without atrial fibrillation. How was the use of ECG monitoring during the first months post-stroke? We see that it was used in less than 1/3 of patients for 24-hour Holter monitoring, and less than 1% received prolonged ambulatory ECG monitoring. And if you compare on the right side of our diagram, you see the light gray bars. This corresponds to the use of brain imaging. The middle bar is for echocardiography, and the black bar is for ECG monitoring. So in spite of the fact that ECG monitoring is compared to the other techniques a very simple tool, it's largely or poorly used in clinical practice. How can we perform adequate ECG monitoring? This systematic review shows us the options, and it's interesting to note that when we use 24-hour Holter recording, we will detect atrial fibrillation approximately in 5% of patients, and we can detect the same almost 5% by repeat multiple ECG recordings. And these authors try to quantify this, the number or the total duration of these intermittent single lead recordings. And as you can see, Repeat recordings of a total duration of 19 minutes correspond to, in terms of efficacy, they produced a similar AF detection rate to typical 24-hour Holter monitoring. However, we have in the recent years gained new fascinating technologies. We have very user-friendly ECG, surface ECG recording system, which allow for long-term monitoring of a week or even more. The patient can shower with them, and so they are very user-friendly. On the other hand, we have implantable loop recorders, implantable cardiac monitors, which offer us continuous several years of duration recordings, and in addition they offer also the option of remote monitoring of these patients. This is an example from our practice which shows a 62-year-old lady post-cryptogenic stroke who was referred to our center for implantable loop recorder implantation, and relatively early after detection atrial fibrillation was detected, as you can see on the top of the histogram, and anticoagulation was started. Now we have, however, not only real-life evidence, we have experience, we have randomized clinical trials. As this is one of them, the Crystal AF trial, which randomized patients to standard ECG monitoring, and it compared to the strategy of implantable cardiac monitor. And as you can see, the rate of detection of atrial fibrillation were hugely different. After 6 months, it was more than six times more patients had detected atrial fibrillation. After 1 year, it was more than 12%, more than 7 times more with implantable loop recorders compared to standard approach, and after 36 months, it was 30% compared, so more than 8 times, almost 9 times more. So really this shows that, that in patients with cryptogenic stroke, undetected paroxysmal atrial fibrillation may be a cause of stroke, and ECG monitoring with an implantable cardiac monitor is superior to conventional follow-up to detect atrial fibrillation after cryptogenic stroke. We have also other trials, which is the Canadian Embrace trial, which and the diagram shows the incremental yield of prolonged ECG monitoring for the detection of atrial fibrillation in patients with cryptogenic stroke during a 30-day monitoring period, which was applied within 90 days after randomization after the stroke. And you can see that with the 30-day monitoring, 16% of patients had atrial fibrillation compared to only 3.2% with standard 24 hours Holter monitoring. So this is interesting mainly because, as you can see in the bottom line, it has a very important therapeutic impact. In the group with the extended ECG monitoring, the proportion of patients who were switched from simple antiplatelet therapy to anticoagulation therapy was much higher compared to the standard process. So, and this is basically the aim. Why do we do that? We do that to identify patients who should be anticoagulated. This diagram shows the results from a German trial, embolic stroke of undetermined source and long-term ECG monitoring. Again, you see with implantable loop recorders, 24% of patients had atrial fibrillation after 13 months of monitoring. This meta-analysis tries to summarize part of the knowledge we have, and it shows that the proportion of patients diagnosed with post-stroke atrial fibrillation by implantable loop recorders is approaching 17%. And this diagram nicely illustrates the relationship between duration of ECG monitoring and detected atrial fibrillation event rate. The message is in fact very simple. The longer you monitor, the more atrial fibrillation you will find. So with monitoring less than 3 days, it will be approximately 6.5% in this trial. With more than 7 days, it is 9%. And with 180 days of monitoring with implantable loop recorders, it approaches 30%. This diagram shows a proposal for an algorithm for the identification and diagnostic evaluation of patients with cryptogenic stroke. There is a standard evaluation, and as you can see, there is a basic electrocardiographic evaluation together with the monitoring in the stroke unit. From the cardiologist's point of view, there is also the need to perform echocardiography, transthoracic and transesophageal. If we do not find reason and clear etiology, then we should continue in an advanced setting with a more prolonged time of monitoring. And if even this does not bring us to any result, so this is a place for implantable loop recorders. However, I would like to here also stress that virtually all patients in our practice in my country have detailed echocardiographic evaluation post-stroke, but very few have extended ECG monitoring. Now, this diagram shows that to a certain extent we can predict the probability the patient will have atrial fibrillation based on simple clinical scenario scoring system. And these data from France compare CHED score and CHED-VAS score, and what they have in common that the brown line on the left corresponds to the highest CHED score, and the green and blue line at the right side of the slide correspond to highest CHED-VAS score. So the higher the CHED-VAS score or the CHED score, the higher is the probability you will detect atrial fibrillation. We have also a specific scoring system in post-stroke patients. It's called HAVOC. These are the acronyms of the criteria, of the clinical criteria, as you can see them in the table. And the advantage here again, or the aim, is to identify patients who will have a high probability of atrial fibrillation. This can help us to use implantable loop recorders or advanced monitoring techniques very precisely and on an individualized basis. So you see the red line corresponds to a high HAVOC score and corresponding high probability of detecting atrial fibrillation. In this case, it's 25%. So why do we need this information? Well, this is in fact all these technologies bring us a new challenge for cardiologists. First of all, I believe that all patients post-cryptogenic stroke should be evaluated by cardiologists that are knowledgeable about long-term ECG monitoring and the tools and the interpretation. And in the case that atrial fibrillation is detected, oral anticoagulation should be initiated with atrial fibrillation episode detected. And these are the recommendations from the European Heart Rhythm Association document from 2017. In this case, anticoagulation should be initiated with atrial fibrillation exceeding 5.5 hours. However, a word of caution, in patient really who we believe is on a very high risk of embolic, thromboembolic stroke, we can certainly put our threshold also lower, and I believe Georgios will talk more on that. So can we predict high probability of atrial fibrillation detection post-stroke? Yes, we have simple clinical scoring systems which can help us to better identify the patients for an elaborating screening strategy. A word of caution also on this slide. If we perform continuous long-term ECG monitoring in all stroke patients, we will find especially short-term atrial fibrillation episodes relatively frequently in about 30% of patients. So really this is an issue we have to judge, assess this in clinical context and decide on anticoagulation on a very individualized basis. These data from the ASSERT trial have shown that we sometimes could be maybe more conservative. These data have shown that only subclinical atrial fibrillation lasting more than 24 hours was associated with comparable risk of ischemic stroke. However, this was not in post-stroke patients. This was in a population of hypertensive patients aged over 65 years with no prior stroke who were implanted with devices. So, ladies and gentlemen, let me summarize the current role of ECG monitoring for the management of post-stroke patients. In patients with cryptogenic stroke or ESUS is recommended by the international guidelines, but in real life we underuse it, unfortunately. The use of ECG monitoring devices enabling prolonged monitoring is a feasible and attractive option to better identify patients with subclinical atrial fibrillation. The importance of post-stroke prolonged ECG monitoring is emphasized also by the recent trials dealing with unselected oral anticoagulation. You will hear on this topic later. Implantable loop recorders are clearly superior in detecting post-stroke atrial fibrillation. Their cost effectiveness may improve by using risk stratification. We certainly learn a lot by monitoring. We learn especially on the issue of causality or just stroke atrial fibrillation association. And demonstrating atrial fibrillation presence in up to 30% of patients with cryptogenic stroke has important anticoagulation-based therapeutic implications for secondary prevention. Thank you very much.
Thank you, Robert, for a very clear and informative presentation. And we indeed have a great response from our audience. So let's have a look at some of the questions that poured in. Here's one. Should all patients with TIA be fitted with an ICM as well?
Well, I believe that first of all in clinical practice, patients, at least in our part of the world, patients with TIA do not pay frequently too much attention to this event, especially if it goes after a couple of minutes. I believe it's a very serious event. It's a very serious symptom which can prevent a disaster. So my feeling would be that we should seriously consider an implantable loop recorder in every patient with clearly diagnosed, neurologically confirmed transitory ischemic attack.
Georgios, what do you think?
Yes, a transient ischemic attack is not a very strong endpoint, and it's a diagnosis that can sometimes be challenged. But if there are clear-cut indications that there was a transient neurological dysfunction like hemiparesis, diplopia, not like sensory deficits, then I would do brain MRI with diffusion-weighted imaging, and even if there are no symptoms, if there is evidence of infarction on brain MRI, then for me this is a stroke, like Robert.
This is what I believe.
Absolutely.
Based on the tissue definition, not on the time definition. So if there is brain infarction, this patient needs to undergo prolonged cardiac monitoring and be implanted.
So in those patients, even the TIA patients may benefit from an implanted device.
Yes.
Thank you. Another question that came in is, what would you do if a patient with cryptogenic stroke and an implantable cardiac monitor has only 10 minutes of atrial fibrillation?
Well, I believe this is not an infrequent scenario. In this case, I would look at the thromboembolic risk score, at his chest-vest score, possibly also on other biomarkers. And if, according to these criteria, he would represent the patient with high risk, I would initiate anticoagulation.
Mm-hmm.
Yeah, I would feel the same. I would feel very strongly in favor of anticoagulating this patient, provided that he has undergone a comprehensive diagnostic workup and other causes of brain ischemia have been excluded. So a 10-minute episode of atrial fibrillation in this patient is a very good reason for me to initiate anticoagulation therapy.
Very clear answer. Thank you very much. The next question coming in cryptogenic stroke patients, how many Holters would you make before actually choosing to implant an implantable cardiac monitor?
Well, I must say it depends on the technology you are using. The standard Holters, as we know them from a couple of years ago, are not terribly user-friendly, and patients are not very happy with them. So it limits you in many activities. The modern devices, which are in fact patches with a small piece of kind of USB, kind of memory flash, are much more user-friendly. I would say that with these devices, with the modern devices, I would probably go for something like 1 week monitoring. With the old devices, I would not do more than three Holters.
3, okay.
I would do a 24-hour ECG monitoring, Holter monitoring, only one, and then if it's negative, I would go directly to implantable cardiac monitoring, because as Robert showed, and I will also show, the yield of AF detection in cryptogenic stroke is related to the duration of monitoring. The longer you monitor, the longer you seek, the more you're going to find. So why not move directly to the most effective option? So my approach is more aggressive. I move after 1 Holter to implantable cardiac monitoring.
That's a very clear statement, and also probably kind of a bottom line of your presentation. The longer you monitor, the more likely you will detect the high-risk patients, the AF. So this is really a bottom line information from this. Thank you. And the last question on this is there any head-to-head data between different ICMs?
I'm not aware of that, of head-to-head comparison of various devices. They have specific differences. They have various algorithms to evaluate the presence of atrial fibrillation. But I believe all of them serve this purpose. That they give us a very, very detailed image of the electrocardiographic proarrhythmic milieu in that particular patient.
Okay.
Yeah, I'm not aware of any head-to-head comparison, at least a randomized one. I don't know if you're aware of Wolfram of such a study.
Certainly they differ in size and
to identify the AF episode is the key issue.
Exactly.
Yeah. Okay.
So it doesn't matter what you use.
Okay, thanks to both of you for all these answers, and thanks again, Robert, for your valuable insights.
Thank you.
And now we move to the second presentation, and we will hear from Dr. Tsivgoulis, who will talk about his experience on personalized treatment and how prolonged cardiac monitoring can prevent secondary strokes. Over to you, Georgios.
Thank you. First, I would like to express my appreciation for the kind invitation to participate in this webinar with our esteemed colleagues. This is my disclosure slide, and we all know that ischemic stroke represents a heterogeneous group of CNS disorders with different ischemic causations, including extracranial or intracranial atherosclerosis, cardioembolism, small vessel disease, paradoxical embolism via patent foramen ovale, and other causes. In a substantial portion of patients, despite a comprehensive workup, the underlying mechanism of cerebral ischemia is not identified, and these patients are classified as cryptogenic stroke. We need also to keep in mind that there are two other subgroups that are lumped into the cryptogenic stroke subgroup. Those patients with two or more causes, and those patients with incomplete evaluation. So the definition of cryptogenic stroke was heavily criticized because of its heterogeneity, and a new clinical construct was introduced, and the term was ESUS, standing for embolic strokes of undetermined source. So these were cryptogenic stroke patients with comprehensive workup who had not a lacunar cause of stroke, and there was no evidence of hemodynamically significant large artery stenosis or cardioembolism. The main hypothesis behind the ESUS definition is that these patients had the main underlying mechanism of atrial fibrillation as the cause of their cerebral ischemia, so it would make sense to anticoagulate indiscriminately all these patients, and this would reduce the risk of stroke recurrence. So this hypothesis was tested in two large phase 3 clinical trials, RESPECT ESUS and NAVIGATE ESUS, and we're going to discuss about this later. First of all, I want to underline that the most common mechanism of cerebral ischemia in different population-based studies from Europe and North America is cryptogenic stroke, accounting for 30 to 46% of all ischemic strokes. And this was recently shown in the largest population-based study in Greece, where cryptogenic stroke represented 46% of all ischemic strokes. What we learned from the two NAVIGATE ESUS and RESPECT ESUS RCTs is the following. Indiscriminate anticoagulation of ESUS patients with rivaroxaban increased substantially the risk of intracranial bleeding and systemic bleeding. Similarly, the anticoagulation of these patients using the bigatran resulted in high rates of clinical relevant non-major bleeding and high rates of major or clinical relevant non-major bleeding compared to aspirin. So we hurt these patients if we give them oral anticoagulation, because this is associated with high risk of bleeding. Another argument against the indiscriminate anticoagulation of cryptogenic stroke patients is shown in this table, where different studies using implantable cardiac monitors have been tabulated, and you can see that the atrial fibrillation represents the minority of the cause of cerebral ischemia in this subgroup, ranging between 9 and 46%. And this was also shown in a secondary analysis of Crystal AF study, where patients who were eligible according to the RESPECT ESUS and NAVIGATE ESUS criteria had only in 1/3 underlying AF during implantable cardiac monitoring for 3 years, and we can see that there was no difference in the rate of atrial fibrillation detection between non-ESUS cryptogenic stroke and ESUS cryptogenic stroke. So the same criticism that stands for cryptogenic stroke is also evident in the definition of ESUS. There is substantial heterogeneity of potential embolic sources, including artery-to-artery embolism in patients with non-hemodynamically significant intracranial or extracranial stenosis, embolism via PFO in young stroke, cryptogenic stroke patients, cancer-associated embolism, and of course, embolism due to minor cardiac sources, including valve disease or atrial cardiopathy. So this is the main reason why the two trials were negative, because we included heterogeneous patients that did not benefit from oral anticoagulation. And now we have very strong data from 3 large RCTs indicating that the indiscriminate anticoagulation using vitamin K antagonist or NOACs is not superior to aspirin in terms of secondary stroke prevention. And in our recent meta-analysis, we showed that NOACs were not related to lower risk of recurrent stroke compared to aspirin after pooling data from the two ESUS trials. More specifically, in the Navigate ESUS trial, the rates of secondary stroke prevention were identical between rivaroxaban and aspirin, and they were 4.7%. Similarly, in the RESPECT ESUS trial, the difference between dabigatran and aspirin was very low, only 0.7% in terms of ischemic stroke prevention, and this was not significant. Our recent meta-analysis included 28 studies where patients with cryptogenic stroke were evaluated using implantable cardiac monitoring, comprising a total of 4,500 patients. The mean yield of AF detection was 23%, ranging between 20 and 27%. And there were two main predictors of increased AF detection: increasing age and increasing duration of monitoring. And as you can see in these plots, there is a positive linear association between the duration of monitoring and the yield of AF detection. And this can be translated into simple numbers. So if you implant a patient for a duration of less than 6 months, the yield of AF detection is only 4%. It goes up to 20% when the duration of monitoring is between 6 and 12 months. It goes even higher to 26% when the duration of monitoring is between 12 and 24 months. And then it is even higher to 34% when the duration of monitoring exceeds 2 years. What is interesting is that there is no difference in the rate of AF detection between cryptogenic stroke and ESUS. So this is another argument that ESUS may not be clinically meaningful. And then there is no difference between the elapsed time between the onset of cerebral ischemia and the date of cardiac monitor implantation. Another important argument in favor of implantable cardiac monitoring comes from this elegant meta-analysis that evaluated the association between subclinical device-detected AF and clinical AF or stroke risk in patients with cardiac implantable electronic devices. As we can see, the detection of subclinical device-detected AF was associated with more than a 5-fold increase in the likelihood of detecting clinical AF and with more than a 2-fold increase in the risk of stroke. And this provides strong evidence that subclinical device-detected AF is harmful and results in increased stroke risk. So our recent meta-analysis wanted to test the hypothesis that prolonged cardiac monitoring by discovering a high rate of AF and prompting anticoagulation in this patient may result in better outcomes in terms of secondary stroke prevention. This is the PRISMA flow chart of our meta-analysis, including 4 studies. 2 of them were randomized, Crystal AF and Find AF. 2 of them were observational studies from Spain and US. We included approximately 1,100 patients. And in this table, the 4 included studies are shown. I want just to highlight that the duration of monitoring was variable between the 4 studies and ranged between 6 and 30 months. But the AF detection threshold was very low, only 30 seconds. So we're talking about subclinical AF. What our meta-analysis showed was the following. First of all, prolonged cardiac monitoring was associated with a 2-fold increase in the likelihood of AF detection, and there was no heterogeneity across the 4 included studies. This resulted in a 2-fold increase in the initiation of anticoagulation therapy with 0 heterogeneity across the 4 included studies. This in turn resulted in a 55% reduction in the endpoint of recurrent stroke, again without any heterogeneity across the included studies, and this also translated in a 50% reduction in the risk of recurrent stroke or TIA without any heterogeneity across the included studies. So the main take-home messages from my presentation is, first of all, subclinical device-detected AF can predict clinical AF and increase stroke risk, and we need to take seriously this subclinical device-detected AF, and we need to anticoagulate on our patients. Prolonged cardiac monitoring can be associated with reduced risk of recurrent stroke due to higher yield of AF detection and timely administration of oral anticoagulation therapy. ESUS still represents a group of heterogeneous disorders with different causes of cerebral embolism, and this definition needs to be further refined if we want to use it in our clinical practice. And today, I think that implantable cardiac monitoring represents the best available tool for a more individualized diagnostic approach in cryptogenic stroke. Henry Louis Mencken, who was an American journalist and scholar, quoted that for every complex problem, there is an answer that is clear, simple, and wrong. All stroke physicians all over the world know that the optimal therapeutic and diagnostic approach to cryptogenic stroke represents the most hot problem, the most hot topic in current stroke medicine. I strongly believe that the one-size-fits approach with indiscriminate anticoagulation in these patients that you can either call cryptogenic stroke or ESUS, doesn't matter, is wrong. And I think that we need to use implantable cardiac monitoring to detect those patients that will actually benefit the most from anticoagulation therapy. Thank you for your attention.
Thanks, Georgios, for this fascinating presentation. And we have again had a great response from a very vivid audience. And again, so I would like to go directly to the questions and put those questions to you. First here is, what is the relation between the clinical and subclinical AF?
Yes.
Georgios, starting with you.
As I showed earlier in my meta-analysis, most of the episodes that we detected were subclinical AF patients. And the anticoagulation of the subclinical AF patients resulted in a 55% reduction in secondary prevention of stroke. So, as Robert said, patients with cryptogenic stroke or high-risk patients for a new recurrent stroke, and this will be devastating. So it doesn't matter if it's clinical or subclinical AF. If we detect AF, then we treat and we anticoagulate. This is my approach.
Thank you. Robert?
Well, yes, this is a very, very principal question, and I think there is some hesitation about the exact definition. But in my understanding, subclinical atrial fibrillation is a fibrillation detected in a patient who is asymptomatic, which is, from the clinical point of view, it's subclinical. And I would add also that it was detected by a tool which is relatively novel and was not in the past part of the standard evaluation. So we have implantable loop recorders, but we have also new information coming from implantable devices, from pacemakers, from defibrillators, and even now we have probably an avalanche of information coming from all kinds of wearable detectors and smart watches and similar technologies. So these are all subclinical atrial fibrillation, but I would like to emphasize that 70% of patients with atrial fibrillation are usually asymptomatic. So they can theoretically run for years in atrial fibrillation because nobody performed an ECG. So they were for 3 years subclinical, and then randomly on a completely different occasion making an ECG for hip replacement, they found atrial fibrillation. So it was subclinical for many, many years, but now it became clinical.
So the subclinical may even put an additional risk to the patient, because not knowing you are at risk is even more dangerous than being aware of something needs your attention. Yeah, I agree that the subclinical AF is also a very high risk condition. Next question I would like to put to you is, what is the relevance of ESUS after the 2 negative trials? Is this concept now totally sort of abundant, or how do we deal with ESUS from now on?
ESUS was a very comprehensive approach to try to refine the chaos that represented the cryptogenic stroke definition. But it's a good effort, but not good enough. So we need additional criteria to further reduce the number of patients that are classified in this category in order to be able to make clinically relevant decisions. For the time being, I don't see a clinical role in ESUS unless the definition is further refined using neuroimaging, echocardiographic, and biochemical parameters, for instance, pro-BMP. Okay.
Robert, you mentioned in your presentation this score, the HAVOC score, which adds further risk factors potentially to identify those patients with high risk. What do you think of the ESUS concept as it is now, and can it evolve to something useful?
I believe that these kind of relatively simple clinical scoring systems are made to improve, I would say, the efficacy of using these new technologies. That means if we have really a patient with a high HAVOC score, this patient has a very high probability that he has atrial fibrillation, subclinical. However, the results from these new trials have shown that what I call also flat rate anticoagulation is not the right way to go. But we can identify by, for instance, HAVOC score, the patient who very probably has atrial fibrillation, and he deserves the implantable loop recorder. And this can be a very strong argument also for those who would say, okay, but is it really cost effective? I mean, if we pre-select in this way the patients, even in very in countries where economic aspects are important, I think this is a very strong argument to use it, because the probability that it will have therapeutic impact, this is important. I don't want to monitor him to have more scientific data. I want to monitor him so it has a therapeutic impact, and this is anticoagulation. This can help.
And technical development will certainly evolve and improve in the course. And next question right fits to that question, also coming back to your presentation before. Where do you feel wearables such as watches may have a place in early detection in AF?
Well, certainly this is a booming market. This is a booming technology. If you look what happens in the last years, the various manufacturers have a competition who will offer better features on these devices. For the moment being, even with a trial which was presented this spring, the Apple Heart trial, we know that it creates an avalanche of information. However, this information was not until now validated. And this happened also in this trial, because it was mainly used in relatively young patients where the probability is very low. Then it was the confirmation by a standard ECG was not at a percentage we would like to see. So this, for the moment, is not a validated method. And for the moment, I'm also a little bit afraid, because there is an old English proverb, I think it comes from Wales, that an apple a day keeps the doctor away. So with various variables, I think we have to be a little bit careful not to overuse medical services.
Yes, okay, thank you.
I agree that the wearables need to be externally validated, and more importantly, they need to be linked to prevention of outcomes. Because we know now that implantable cardiac monitoring can reduce recurrent stroke, so we need to have similar data before implementing them into our clinical decision-making process.
Absolutely.
Maybe I would add that very certainly a huge progress in this technology. The new models offer us the possibility to record ECG, validated FDA-approved ECG recordings. So this might certainly change the relevance of this information, the validity of this information.
Well, I think it also came out quite clearly from both of your excellent presentations that the medical expertise needs to accompany the technical advantage. and only in combination with medical evaluation and judgment, those tools may eventually turn into a benefit for those patients.
Absolutely.
Thanks again for all these answers. Great. Well, thank you to our distinguished speakers for answering our viewers' questions and for your valuable insights. During this webinar, we have learned that many patients with cryptogenic stroke have underlying atrial fibrillation, which increases their risk of stroke, and that monitoring below 30 days may miss the majority of AF episodes. We reviewed the 2016 ESC guidelines and the 2019 AHA guidelines that recommend both long-term monitoring with implantable cardiac monitors in those patients with cryptogenic stroke. We also looked at how important a personalized approach is to treating these patients, and that a simplified and one-size-fits-all approach does not work. So that was Professor Hatala and Professor Tsivgoulis speaking to us live on this fascinating topic. It's been a great pleasure having you with us today. Thank you.
Thank you.
And thank you, our audience, for joining in and being so interactive. Thank you and goodbye.